Okay, so last lesson for the semester. You've seen the recordings, right? For this and also for chest trauma. Again, a reminder for chest trauma, focus only on recognition and management because most of them are emergencies. So make sure you can identify, especially the life-threatening ones, namely tension pneumothorax and flail chest. Okay, so recognizing them and then your actions that follow. Most of them will entail that you notify somebody, rapid response, okay, and then there are some ABG questions, maybe two. This is always tied to the mechanical ventilator and also under respiratory failure. So the question may not be as straightforward as asking you to interpret an ABG. So it may be complex because you need to decide on an action. So the question will be an intervention, but then the answer will be based on your interpretation of the ABG. Does that make sense? So let's say, remember how do you assess oxygenation in a patient who is on a mechanical ventilator? Because they're sedated. So subjective will be out of the question. So how do you know the patient's oxygenation status? ABG, right? And then of course the patient's um, behavior, right? So if they're restless, for instance, fighting with a vent, right, or grimacing, something like that. So that's all you're seeing. Okay, so as far as mental status changes go, so the patient's behavior, and then you'll have to rely on vital signs as well as the ABG. Now, depending on the ABG results, will determine your next action. Okay, so let's say the patient is in metabolic acidosis. So what will be your action? So someone with metabolic acidosis means that their CO2 is very high and oxygen is okay, low. Then so therefore your decision will be based on, well, what currently is the mode being used, right? And then if you can keep them there, what changes would you want to make, increase the FiO2? But all this data will be given to you. Okay, so what are the current settings? All right, so that's one of the uh, next gen questions you'll expect to see. Okay, where you'll see ABG. Um, yeah, maybe two of those. All right, let's go to the liver. First, let's review briefly what is the anatomy. So where is this located? Let's say I put a hotspot question. Where would you palpate the abdomen to locate the liver? Okay, make sure this is the picture, right? So therefore, this will be the picture's right side, okay? Not your right side, all right? So the upper right of the abdomen. So there it is. Now let's look at although this figure does not show the blood vessels, so let's just imagine. So there's a big vein running through the liver. That vein is called it's called the portal vein, or you can also call it the hepatic vein. But that gets bigger because that thing becomes the inferior vena cava. Okay, so because this is the last organ before the blood enters the heart, correct? So therefore, all the venous circulation, literally from the esophagus and to your toes, and from your toes, they empty into the liver. All of them pass through the liver. Okay? And then, of course, what will the liver do as that blood passes through it? Clean it. Okay, so any drugs that passes through there, it'll metabolize those drugs. Any toxins, they'll do the same. Any waste products, particularly ammonia, will be destroyed, right? And then eliminated. Okay, so therefore, as every red blood cell, every ounce of blood passes through it, it's cleaned. Okay, and then waste products will be destroyed, drugs will be destroyed. Well, that's why we have the half-life phenomenon. Yeah. Okay. Now, the beauty and also the disadvantage of the resiliency of this organ is, yes, even if let's say you're alcoholic for 50 years and you're pretty much cooked your liver, now let's say you only have 5 to 10% left functioning hepatocytes, right? It will still work. It will continue to do its job, cleaning, metabolizing, okay, up to the last functioning hepatocyte. It will do its job. That means when symptoms appear, it's usually too late. Okay, especially with some chronic causes. Let's say you're drinking every day, right? So you won't see damage every day because you've been doing it for so long. Unlike, let's say you ingested a whole bottle of Tylenol today. Of course, is that acute or chronic? That's acute. That's a different story. Okay, so you'll see symptoms right away. Or let's say you have acute hepatitis, for instance, from a viral, for instance, or drug-induced hepatitis. So you'll see acute symptoms. However, for chronic causes like alcohol, for instance, or hepatitis B does not have an acute phase. Okay, these are chronic. Hep B, Hep C, Hep D, these are chronic forms. A and E, they do have acute episodes. Okay, so those are exceptions. But for the most part, we're gonna see chronic issues here. So therefore, when when the cause is chronic, by the time the patient manifests signs and symptoms, the condition is already way advanced. Okay, because of what's the reason for this again? It's very resilient. So even if only 5 to 10% is left, it will do its job, okay, to the best that it can. So that when you see symptoms, that means all of it is gone. Okay, there's no more hepatocytes left. Okay, probably less than 5%, which is good as nothing. All right. So these are your hepatocytes. Okay. So these are the functions of the liver. And then keep in mind, these will disappear when your liver fails, whether it fails acutely or chronically. So if it's chronic, then the function will diminish. Okay. So let's start with glucose metabolism. That means, can it still turn glucose into glycogen? No. So you have less oxygen storage, ammonia conversion. Okay, so you'll have high levels of ammonia in your blood, leading to encephalopathy. You'll have mental status changes. Okay, you go crazy. Okay, because you're poisoning your brain. Protein metabolism. So you cannot metabolize or make protein. That's the major function. You can eat all the protein in the world, but if your liver can't metabolize it, you can't make it. So therefore, albumin levels drop. So what happens to plasma oncotic pressure?
It drops.
Drops. So can water stay in your plasma? No. So you'll have edema. Okay, everywhere you'll have third spacing. Yeah, we call that third spacing because this is not unlike edema, wherein edema was caused by hydrostatic pressure, correct? This one is caused by yeah, decrease osmotic pressure. Okay, because there's not enough albumin everywhere in the not in the blood, not in the body. Yes,
Protein, but your body can't metabolize it. And where does it go?
just out of your body. Yeah, back into the toilet.
That doesn't
Okay.
increase ammonia levels as well.
Depends on the condition of the liver and also of because this is related to the kidneys as well. But we have something called hepatorenal syndrome, meaning once the liver fails, the kidneys are going to be next. Okay, even if you did not do anything to the kidneys, but because of liver failure, the kidneys will get collateral damage as well. Hepatorenal syndrome. Then what vitamins are stored in the liver? A, D, E, and K. Okay, so K is, of course, it's responsible for clotting factors. Okay, so we need vitamin K to make clotting factors together with protein, of course. So clotting factors are made of protein. So you need protein and vitamin K to make clotting factors. So if both are gone, what happens to your bleeding time? increases. Okay, clotting factors drop, bleeding time increases. Bile formation. Why do we need bile?
To digest.
Digest fat. So inability to digest fat, what will happen to your feces? Because now it will go into your feces. All right. Now you'll have bilirubin excretion as well. So this is why you turn yellow. Okay, because you cannot excrete bilirubin. So bilirubin is of course a byproduct of red blood cell destruction. Okay, so natural cycle. We destroy red blood cells die, and they're usually recycled. Okay, so they're recycled in the spleen, and then that's why your feces is brown and your urine is yellow because of bilirubin excretion. Okay, so if you can't excrete that, that's why where will the body put it? Everywhere in your skin and your eyes. That's why you turn yellow. Okay, so bilirubin levels increase. And then, of course, drug metabolism. So once you have liver failure, that limits our choices with drugs. There's, of course, exceptions. We have to give you drugs somehow, but just know that drug metabolism is decreased or non-existent. So every drug we give this patient who has liver failure will either accumulate or cause more toxicity, okay, in the body. Okay, true or false?
False.
False.
All right.
Which one do you supply to the liver situation?
Yeah. That's it.
All right, so these are the studies we'll be expected to see or ordered by the physician. So AST, ALT, these are your liver enzymes. You can also have the others, but majority will be AST and ALT. Okay, and of course, protein studies, which will show decreased in liver failure, bilirubin levels, clotting factors. They usually order bleeding time, PT, INR, or PTT. Then ammonia, lipids. Now, this table you'll see here, it will show the levels once you have liver failure. Okay, which ones will be elevated, which ones will be decreased. Yeah, question?
Oh, what about cholinesterase and what is GGT?
Glut something. It's not again. It's not very significant. So I would focus on AST and ALT. So
Knowing the
when
levels, do we have
yes.
to know the levels for that?
Right, because some questions may just, as far as I can remember, there are normal ranges given, but just in case it does not, so you at least you know. Correct. Now, one thing about AST, ALT, since they're called aminotransferases, okay, so when you hear the term transaminitis, that is an elevation of these two. Do you get it? So on, let's say you read a case study question, right? And then one of the diagnoses is transaminitis. That's what it's referring to, that these are elevated. Again, what does transaminitis mean? Elevated AST, ALT. Are we clear? Okay, and then the doctor will, of course, investigate what's causing this transaminitis. Is it drug induced or is it chronic liver failure? All right. Like I said, these are indicators. So when these are elevated, of course, that means there is liver damage, liver injury. Now we have to indicate or find out whether it's acute or chronic. For here's GGT, gamma glutamyl transferase. Okay, it's still one of the transferases, but again, we focus on ALT and AST. Here are other tests. You can do biopsy, ultrasound, CAT scan, MRI. These are some questions we ask. Okay. Reason for this is, let's say we have transaminitis, correct? So there are three main causes of liver failure or cirrhosis. Number one is alcohol, especially in America. Actually, worldwide. Okay, so we call it Lennox cirrhosis. Lennox is spelled Laennec, and then apostrophe S. Lennox, or that's also referring to alcohol cirrhosis. Next is viruses, meaning you have hepatitis B, C, or D that can lead to liver failure as well. Unlike before, 30 years ago, there was no known treatment for hepatitis B, C, and D, only for A and E. Now we do. We have treatment for B, C, and D now. We have antiretrovirals, same medications used for HIV. Okay, so we have drugs now to treat hepatitis. Okay, hepatitis B, C, and D. Before it was like HIV. No, it was a death sentence. Yeah, you have it forever. Now no more. We can treat it now. And then third is obstruction. Or specifically biliary obstruction. So liver failure can also result from obstruction of this tree right here. You've heard of cholecystitis, right? Yeah, so gallbladder inflammation. Okay, so if that's not treated, that can actually lead to liver failure as well, because the enzymes go back and then auto digest the especially bilirubin. Okay, and that damages the liver. So therefore, pancreatic duct or even pancreatitis can also lead to liver failure. Okay, so these are what we assess. Okay, so do you have cirrhosis? Your alcohol, how much do you drink? Infection refers to the viral hepatitis. And then fatty liver disease. This is, of course, caused by high cholesterol. Okay? Although fatty liver disease is treatable, of course, this is caused by high cholesterol, so statins can treat this. So these are the common, so on the chapter, these are treated separately. Okay, so there are different sections for jaundice, portal hypertension, ascites, and varices. Although they're together in one bullet here, they're actually separate sections. Okay, so jaundice, right?
Yeah.
Meaning yellowing. Okay, so yellowing of the skin and the whites of your eye, your sclera, of course, indicate high bilirubin levels, right? So that can either be caused by liver failure, or like I said earlier, it could also be obstruction. Okay, let's say you have severe cholecystitis, for instance. Okay, so it may temporarily turn your skin yellow, okay, until you get treatment. But for the most part, generally speaking, when you see jaundice in anybody, that usually indicates acute or chronic liver disease.
That's what, let's see, like the tea-colored, urine.
Yes, because bilirubin again is also excreted in the urine, so that way it will turn the urine really bright orange or
Dark
like Coca-Cola. What color is that?
brown.
Yeah, soda. Okay, Coca-Cola. Yeah, almost dark brown. Okay. Portal hypertension. So you saw the figure earlier. So here again, all the blood coming from your esophagus down to your toes have to pass through the portal vein. So if let's say you cook this liver because of alcohol or from viral hepatitis, for instance, untreated hepatitis, what will happen to its volume? Will it increase? It actually shrink. Okay, so when you shrink, what happens to the blood vessels running through it?
A3 gets bigger.
How does that happen? So if I cook this liver, put it on the grill, will that increase the blood vessels? Will it dilate them? Actually, everything will shrink. So if you shrink the overall mass of the liver, you shrink blood vessels as well. So therefore, what happens to the pressure inside? Causes portal hypertension. Okay, so imagine because of obstruction, right? So there's portal hypertension. Now, what happens to the drainage? Remember, all blood must drain into your liver from the esophagus, from your toes, all the way, all the GI organs must pass through the liver. But now you've shrunken it because you had alcohol or you had untreated hepatitis. So now what happens to the pressure inside? increase. So the consequences of portal hypertension are the following. So is this now, there's now a combination here. Remember, functions of the liver was liver metabolism, protein metabolism, right? Plus there is hydrostatic pressure here at the same time. So now two forces are causing edema, causing water to leak out of the blood vessels now. Because one is congestion, correct? That's hydrostatic pressure, plus decreased plasma protein. So now you have third spacing at the same time. So what can result? Where will this edema be? In the abdomen. So you'll see liver cirrhosis patients, they all look alike. They will have big bellies and edematous lower extremities. Okay, regardless of race, from all across the globe, Europeans, Asians or Eastern Europeans, all the way to Africa. If you put them all together in the same ward, they all look alike. Okay, when you have cirrhosis. Okay. Moreover, so that's what we call ascites now. There's water in your peritoneal cavity, right? And then there's varices. Now the varices are varicose veins. Now, yes, you may have varicose veins in your legs, in your, what do you call varicose veins in your rectum? Hemorrhoids, plus the unseen varices, the unseen varicosities here are inside your esophagus. Now, if this is your esophagus, like this, right? This is your esophagus. The varices are not outside. They're inside the esophageal lumen, right here. So therefore, when you swallow hot sauce, tacos, or chicharrones, or whatever else you eat, what could happen to those varicose veins? It'll rupture. It'll rupture and they bleed like crazy. So you'll be vomiting blood. You could die within minutes. Okay, so every patient with liver disease is always assessed for varicose veins. Okay, so and plus if it's already assumed, meaning it's already in their history that they've been having transaminitis for a long time. Okay, it's chronic. We assume there is esophageal varices already. We assume, and if you bet your money there, you probably win. Okay, there's always varicosities in the esophagus.
Can you call
Right.
it?
We'll get to the management. Yeah. Yeah, there are several managements for esophageal varices. You just need to catch it and diagnose it, and then of course treat it. Encephalopathy or coma. Well, the end result is coma. So all my cousins, well, probably 90% of all my cousins on the mother's side, because those are the only people I know. I don't know any relatives on my father's side. All of them were alcoholics, different reasons. Women problems, money problems. They all ended up with drinking. Okay, that was their drug of choice. Okay, so all of them died from cirrhosis. Didn't matter, male or female cousin, uncles, they all died from cirrhosis. Well, one did not. He died from hepatorenal syndrome. He was on dialysis. So basically, yeah, it still, still stem from alcohol. Encephalopathy is the patient now has mental status changes. Okay, so that means level of consciousness will decrease. It will alter. It will fluctuate. Okay, all because of ammonia, basically blood poisoning the brain. Okay, so because of high ammonia levels, and then eventually, in stage 4, you'll be in a coma, and there's no waking up from that. Okay, brain's damaged, brain's fried. Nutritional deficiencies, of course, because of the A, D, E, and K deficiency, then that can result in various malnutrition problems. So that's why you'll see one of the treatments for these patients when they're admitted is they always get a banana bag. Why is it called a banana bag? It's a 1 liter fluid that looks yellow because of vitamins. So we'll put folic acid, B12, lots of other nutrients in there, and then we infuse that. Okay, because these patients are always, well, chronically, they're going to be mineral deficient. So you have to give them every day. Okay, it's not every single day. When do you need vitamins? Once a week? Every day, so they don't have them. Right, jaundice, there's really no, I mean, you just look yellow. It's unsightly, but not really life-threatening. Oh, so treat jaundice as a manifestation. Okay, it's not really going to cause. You just need to treat the underlying causes that led to it. But of course, that will indicate, even if the patient, let's say, had an acute episode, the jaundice does not disappear once your levels are down because it stained the skin. So it'll take months before you lose the yellow hue. Okay,
Do we need to know the different jaundices?
yellow is yellow. What is that in Spanish? Amarillo. Yeah. So there are different causes. Again, you can just this nice to know. Okay, not really testable. Okay, so for portal hypertension, again, this is the root cause of the esophageal varices as well as the ascites. Okay, so these two result from portal hypertension. So therefore, let's talk about management. So what will be part of managing ascites and esophageal varices? What will you expect, or let's say the doctor didn't order it, what will you ask the doctor for?
Thyroid.
This is hypertension, portal hypertension. So how do you treat hypertension? Beta blockers will have to be given. Particularly, doctors will usually order for this. It's propranolol. Propranolol is the drug of choice. So if you see that on this patient's order, that's for portal hypertension. Sometimes you'll see metoprolol as well, because most of them have heart disease anyway, so 2-in-1. So they'll just give you beta blockers. Now, as far as ascites, of course, in addition to beta blocker therapy, for ascites, the patient, unless it's in the later stages, the patient will require weekly. Well, depends on the progression. Sometimes they'll start with probably 4 times a year or 3 times a year. Paracentesis. Paracentesis is will drain this thing. Okay, so they'll insert a needle into the peritoneum and then drain it. Okay. Now, why do we have to do this? Well, if the abdominal cavity is so distended now, it will now affect diaphragmatic expansion. So at that point, the patient usually what makes the patient come to the ER or call 911 is they cannot breathe. So can this lead to respiratory failure? Which type, hypoxemic or ventilatory? Very good. Ventilatory respiratory failure can result. See? So indirect lung injury, yeah? So therefore, non-pulmonary cause of respiratory failure. Okay. So ascites will be usually managed again by beta blocker therapy. Then we have surgical or invasive paracentesis. Now, as far as paracentesis, there's a can't remember if there's a chart or if it's just in the paragraph. So you have responsibilities as the nurse sending this patient to for the procedure. First, of course, you need consent, right? Then next is you have to yeah, so you provide information. Now as far as the preparation, can this patient not really? No, you don't need NPL because this is in the peritoneum. This is not in the stomach. The fluid is in the peritoneum. Okay, it's not inside the so this is this sterile? Yes, because the peritoneum is a sterile cavity. Okay, the GI tract is dirty, but this is sterile. Okay. First thing is if they're on anticoagulants, would it be a good idea to continue? Okay, you may have to hold the day's dose. Let's say they're on heparin, right? Or on Lovenox. May want to hold that for the procedure. Since this is America, they usually order a mapping first. In Asia, they don't. They just stick the needle in and then drain it. Since again, we're I should say, okay, best practice is you have to map the peritoneum first. What is mapping? That is, you'll order ultrasound and then map the peritoneum to see where is the largest pocket. Okay, because this is not going to be on just one section. Remember, you have the stomach, you have bowel, small bowels, you have large intestine, you have the liver, you have spleen, pancreas. There's so many things in there. So the fluid is scattered all over. So we want to maximize fluid drainage by identifying where is the largest pocket located. So we can only see that with ultrasound. And then ultrasound, so the tech will literally mark where the largest pocket was seen. So if they see, this is the largest pocket, they'll put a marker. Then the doctor will, of course, stick the middle of that mark. Then they'll ask the patient to move around, okay, to again mobilize the fluid so we can get as much out. Now, the fluid is always sent, a sample is always sent to the lab because these patients, how long has that fluid been there? A while, okay, a week, maybe a couple weeks, okay, before it accumulated to that size. So they always send it for bacterial presence of bacteria because that can lead to peritonitis. So that way we can treat the patient ahead before these patients get septic. All right. Now, one thing, if this patient is already coming to the ER like more than once a week, one procedure will be suggested to the patient because if they're coming in several times a week, is this like stage 1 or like later stage? This is like end of life, all right? So to improve, part of palliative care will be to do a TIPS procedure. Okay, we'll have tips on one of the slides. To assess ascites, of course, you measure the abdominal girth and also the level of dyspnea. Okay, so you document all that. Aside from the paracentesis, we also have low sodium diet that always helps. Diuretics can also help. So you give them diuretics. Doesn't really matter which one. Usually they order loop. Okay. But I forgot something. What is this patient's blood pressure, expected blood pressure? So thinking that they have low plasma protein, correct? So that means the plasma
It's outside.
correct. So therefore they have third spacing, correct? So what do you expect the blood pressure to be?
Oh,
Is it safe to give diuretics all the time?
No.
Okay, so always consider blood pressure, right? So sometimes now you have competing priorities, correct? You want to get rid of the fluid, but of course it's not safe because the blood pressure is too low. So most of the time, the doctors will order some pressors. Now, it may not always be IV vasopressors. They can add something called midodrine, MID, MIDODRINE. So that's an oral vasoconstrictor. So you can give as much as 20, sometimes 30, or even 40 milligrams, okay, Q8 or Q6 hours. That will help maintain blood pressure, okay, because we still need, because the patient's in respiratory failure, they need that fluid drain, but blood pressure is too low for a diuretic, so they may get both. So administer which one first, the pressor or the diuretic first? Okay, give the midodrine and then monitor blood pressure. Once it's high enough, over 100 systolic, then you can give your diuretic. Are we clear? Okay. Bed rest is applicable for any liver, whether acute or chronic liver disease. Okay. Bed rest. Okay, because you don't want them uh, maintaining the same activity. Because can they? I mean, with low protein, malnutrition? No. I mentioned paracentesis. Oh, one thing about paracentesis is where do you think the needle will be inserted? Up here or down here?
low down there.
Upper, mid, or lower abdomen? Where do you think they'll stick that needle? Where will the fluid accumulate?
Oh,
Up here?
No.
Gravity will push it down. So therefore, it's usually here in the lower abdominal region. Now, what organ is also there? So what do you may want to make sure? Okay, have them buoyed before you send them to the procedure. All right. Of course, weighing the patient is also important. You need a baseline weight before the procedure. That way you can compare how much was removed. Remember how much is 1 pound fluid? How much fluid is that 1 pound? Mhm. This is volume, not weight. Huh?
Wait, what was it?
So 1 pound fluid loss will be 500 ml. Remember we did this in 241. 1 kilogram is equal to 1 liter. Right. So have even more, up to 4 liters can be removed.
Oh, wow.
So would that cause hypotension or?
But yeah, the
Sudden
procedure will
drop?
also cause, yeah. So if the blood pressure drops, they may slow the drainage down or even stop, abort the procedure altogether if the
Oh.
blood pressure drops too low. Okay. But you're not there anyway. That's in the procedure room, so you're not there. Okay, yeah. So have the patient void and of course weigh the patient. Okay, so here's tips. Tips is a last resort. This is not something you do first choice. Okay, this is usually a last resort. Again, usually palliative later stages. The patient's going to die anyway. So might as well make them comfortable. That's the point. Okay, that's the whole point of palliative care, right? But palliative care is not only for end of life, correct?
Yes.
Okay, just want to make sure you understand that. So this is for symptom improvement. So TIPS is a transjugular intrahepatic portosystemic shunt. So it's a shunt. So they're going to insert a shunt through the neck and then into the portal vein. So let's see here. So what it does is, since the liver is fried and you have severe portal hypertension and then ascites, esophageal varices, correct? Okay. So what you're going to do is, since blood cannot pass through the liver, you're going to have to bypass the liver altogether. So you'll create a new highway. So you'll put the shunt through the neck and then through the liver and then into the entrance of the portal vein, because the liver it's gone. It's shrunken. Okay, you cooked it. So now you're putting a new vessel, which is the shunt. So all blood now coming from the esophagus all the way to your toes passes through the shunt and then enters the inferior vena cava. Does that make sense? Okay. It's not really great
Well,
because
Heart failure patients?
okay, so one the benefit, so why did we do this in the first place? It's really to improve or treat portal hypertension in an advanced liver patient, advanced cirrhosis patient. Okay, so this will improve symptoms. However, since you're bypassing the liver, what happens to ammonia excretion? That's the problem, because now you bypass the vein. Remember I said earlier, even if let's say 1-2% of the liver is left, it will work. It will continue cleaning the blood. But now you bypassed it altogether because you're not letting the blood go through the liver anymore because of portal hypertension. You want to improve the symptoms. Now you created a shunt. So now blood goes through the shunt. Okay, still circulates, but doesn't go through the liver anymore. So what will happen to ammonia levels after this procedure? It's gonna get worse, right? So yes, so that's what you watch out for. But does the patient still have ascites though? Are they still high risk for bleeding from the esophageal varices? No more, right? So it improves symptoms. However, ammonia will get worse. Okay, so it's a trade-off. Yeah, patient generally improves, but mental status may suffer. But we have other interventions for the ammonia. Right. This other method is simply another way to put the shunt, but it's not as popular as the TIPS. TIPS remains the best choice. Because when you do the other one, this doesn't really help much with it may help with the ascites, but not the varices. So it's not very popular. Okay, what diuretic is most commonly? I mentioned this earlier. Actually, I didn't. Good catch that. Okay. All right, so for encephalopathy, this is now again damage now to the brain. So watch the patient. They could either go two extremes, either catatonic, like this,
Oh.
obtunded, or they could have violence. Okay, they can act very erratically. They can, punch, kick you. Okay, they don't know what they're doing. Yeah, basically. Here are some of your assessments. Okay, so we're going to EEG to, whether or not the patient still has any brain activity. Again, changes in level of consciousness. Seizures are possible. Fetor hepaticus is simply, what does fetor mean? Feces. Yeah, they say sweet. It's not. It's poop. Okay, it's crap. Okay. Yeah, it's bad breath. Yeah. I don't think it's sweet smelling at all. It's crap. Then you monitor the following. Okay. All right, so here's our management. Of course, eliminate precipitating cause if still possible. And remember, this is caused by usually cirrhosis, but there are other causes, let's say acute drug intoxication, that's treatable. Okay, but so for encephalopathy, the patient will be given lactulose. There is no IV form of lactulose though. So you can either give this orally, or if the patient can't take it or won't take it orally, you give it through an enema.
Oh, boy.
So you've given lactulose, right? Nursing home. So this is a laxative. Now this is the choice because it eliminates ammonia through the GI tract though. There's no other way to eliminate it through the urine. No. So some ammonia may go through the skin. So that's why these patients will have itchy, dry skin, okay, because of the ammonia. So that means we have to do skin care as well, because otherwise they'll scratch themselves until they bleed. So lactulose, the goal is for the patient to have 2 bowel movements, soft bowel movements per day, 2 to 3 actually. We can go, but it's hard to, to get 3, but 2 we're happy. Okay, how many? 2. 2 to 3 is best. Now, patients, of course, learn this thing, right? So even if your patient is old, they know what's going on. When they see that orange liquid, I know what that thing does. So they will refuse it. Okay? So if that happens, now what happens to ammonia excretion?
It builds up.
Correct. So it has to be given via enema or through an NG tube. Or some patients may have a feeding tube. That's even better. You just put it down there and they poop. Okay, how many do we want?
2.
2. So therefore, if they've already had 2, do you need to give more? No. So the dose here will vary therefore. So you may get this 2 or 3 times a day as well. But sometimes the patient won't poop if you give it once. So there's 1 after lunch. That's due. So if they get 2 already, then no need for the second or the third dose. Are we clear? Because what will happen if you give all 3?
Diarrhea.
Now, remember, we have electrolyte imbalances and fluid imbalances already, right?
Yeah.
You have a hypotension, so you don't want to overdo. Okay, so easy on the lactulose. Okay, how many do we want? 2. IV glucose, this will have to be given. So usually infusion D5. For the ammonia, right? So you didn't ask me, where did ammonia come from? It's actually a nitrogenous waste. So this comes from the protein intake. There's a catch-22 here. We do not restrict protein because does this patient have enough protein? No, they need protein. Problem is, if this is in the later stages and ammonia levels are very high, that's the only time we will restrict protein. Are we clear? Okay. So only, let's say, stage 4 encephalopathy, something like that. So when they have asterixis already, actually asterixis comes in stage 2. Okay, so asterixis is flapping tremors. So you have them, okay, raise your hand like this, sir. So they can't hold it steady like this. They will do this. Okay, this indicates meningeal irritation, of the brain. So the nerves are irritated. So you'll have flapping tremors. We call that asterixis. Like an asterisk.
Yeah.
Okay, asterisk. Put an is. That's asterixis. So again, you can give that lactulose through the enema as well, or the patient can't tolerate that. You can also give non-absorbable antibiotics orally. Maybe they can do flagyl. Metronidazole can also be used. These here, sedatives, analgesics, tranquilizers, if possible, okay, discontinue. Remember, drug metabolism is decreased, so this patient will go into a coma if you give these things. Sometimes though, it's calculated. Say the patient has severe aggression, okay, mental status changes, confusion, they're very violent. No choice but to give a calculated dose of a sedative, okay? But that's, of course, unique situations, okay?
So
Because sometimes they happen.
So do you give rifaximin after, or it's not like, it's not a must? You just give lactulose.
First choice is lactulose.
Okay.
And then if that doesn't work, then you can go with the non-absorbable antibiotics. Okay, oral
one is flat.
antibiotics. Yeah, metronidazole.
Okay.
Let's go down to the life-threatening one. So, the esophageal varices. Now, these are again violent bleeding. Okay, this can kill the patient. If they are bleeding, same management as in GI bleed from the peptic ulcer? No difference. So what do you remember? What was given to the GI bleed patient?
Fluid, blood.
Okay, one was, okay, so for if it's esophageal variceal bleeding, octreotide, what does octreotide do again? This is GI vasoconstrictor, right? Okay. But don't forget PPI. Okay, so that's what we gave, right?
Yeah.
So for the bleeding peptic ulcer, so you'll expect to give PPI, okay, either pantoprazole or esomeprazole IV continuous, okay, because they're actively bleeding. And then, so how many IV access do you need here? Because one is dedicated for the PPI, and then you have octreotide as well. That's also going to run continuously. So you have 2, plus you have IV fluids. They're bleeding. Yeah, IV fluids. You have probably blood transfusion. Yes, so now you have 4, right? Are we clear? So you have multiple, okay? So you need multiple IV access for these patients. Central line. Okay. But it's hard because now you're on the watch. It's on your watch, right? So of course it's your patient. Whatever happens to this patient, you can't get an IV, and you're at the mercy of the IV team whenever they come put in that central line, right? So until then, that's your problem. You should have called in sick. All right, so for acute episodes, the patient will have to be given a invasive tube. I think that's on the next. Okay, that's on the next slide. Okay, so this is non-invasive. So treat for shock, oxygen, blood products, IV fluids. You know that. Here's the vasopressin. Somatostatin is the octreotide. Okay, right there, octreotide. Nitro, that's not very commonly administered. We already know about propranolol. All right. So the invasive means is balloon tamponade. So this is a large, the gauge of it's like a Foley, but it doesn't go into the urethra. It goes into your nose, into your stomach. So it's the size is at least 23, can go all the way to 25. That's a huge catheter, okay, to put into your nose. Goes into your nose, down your throat, into your stomach. So what do you see as the problem there? Breathing and swallowing. Okay, so they have to be NPO. Okay, you can't have them swallowing with this tube. You won't see this outside the ER because when these patients come in, they're already bleeding. Okay, the varices, they're vomiting blood, violently bleeding. So usually this is used in the ER. So that's where they end up. So they won't reach your floor. Probably the most you'll see them is ICU. Okay, so from the ER, they'll go to the ICU. But no way they're gonna go to a step down or a med surg unit, okay, with this thing in. Because high risk, again, high risk for aspiration, high risk for breathing problems. Okay. So this thing has two balloons, one in the stomach and then one in the esophagus, obviously. Okay, so you'll be inflating. So there'll be 3 lumens here. So unlike your Foley, you only have 2, right? Because one for the drainage, one for the balloon. Since this thing has 3 balloons, now you need 3. There are 3 lumens here. All right, so one balloon for the esophagus. It would be like a sausage, a type balloon, large, okay, to compress the bleeding veins, and then one in the stomach, okay, to also compress possible blood vessels there, and also to anchor it, okay, so it doesn't pull out. More invasive sclerotherapy. So they'll take you down to endoscopy. You know what is sclerotherapy? This is how they treat varicose veins in your legs. Okay, so they'll inject sclerosing agents. So they basically are destroying the vein. Okay, so they'll put sclerosing, closing the vein, so therefore no vein, no varices. They can also ligate them. Okay, tie them up. Or they can also do banding. Okay, so they'll put a band around the varices. Okay, so the pressure decreases and then they'll go back to normal shape. TIPS is also used. Okay, because remember what led to the esophageal varices? Portal hypertension. So therefore, if you do TIPS, then no more varicose veins, right? Okay. So here, maintain safety, right? These patients, so prepare fluids, expect to be giving blood products, okay, once these things bleed. Breathing, if needed, these patients will also be intubated. Is a renal perfusion. It definitely falls, right? Because you're bleeding, so you're losing blood. So this is one of the causes of hepatorenal syndrome as well. Yeah, pre-renal, intra, or post-renal.
Pre.
Obviously pre-renal. Okay, very good, children. Okay, so here we are and ending now. For hepatitis A and E, fecal oral. So this was now, contaminated food and water. But don't be again too narrow. This can be transmitted sexually through oral sex. Are there microscopic fecal material in the vagina? Yes. So if it's in the choices, oral sexual activity. If it says sexual intercourse, is that a choice? No, because this is oral fecal, so it has to be oral sex. Okay, unless they say sexual activity, then that encompasses oral sex. Okay, but sexual intercourse, no. Okay, that would be for the other ones. So unprotected sexual intercourse would fall under B, C, D. Actually, D. Oh, well, it includes D. So if the sexual partner already has B, then yes, they could get D. Okay. We can forget about G, so they can stop at E.
Okay.
Yeah.
But no.
It's not very common.
No.
Imagine if we had it all the way to Z, right?
No.
So study, again, mode of transmission, very important. Not only for you to practice, but also to educate the patient. Remember, these patients will go home. They need to protect family members and sexual partners, okay? So they need to be familiar, how is it spread? I won't go through the whole thing. Again, what are my questions for viral hepatitis?
Yeah.
Mode of transmission, prevention. Okay, so which ones will have vaccine?
A and B. B.
Only A and B so far. Okay, there's no vaccine for C yet. And again, well, actually, can you prevent D by vaccination? Yes, you can by giving vitamin B, hepatitis B vaccine. Okay, so if you're protected from B, then of course you're protected from D. Right? So if you compare the hepatitis, the acute ones again is RA and E. Okay, so if you look at B, look at the manifestations. Yeah. So unlike A, wherein you have the, acute, abdominal pain, okay. So B hardly have anything. So here's other prevention besides vaccination. Okay. So proper needle disposal, activating the safety device on your needles.
So they give any of those three drugs for B or any of PEG, interferon?
Yeah. So again, same drugs used for HIV.
Okay.
And C. And here's D. And then E. Make sure you're aware that ice comes from tap water,
Yeah.
right? So let's say when you travel, right? So when you're drinking from a bottle, right? That's the advice. You drink only from bottled water. But when you go to a bar now, you order drinks. Remember, the ice is from tap water, right? Oh, I learned it myself. So all my life, when I was growing up back home, I always had diarrhea every day, like all my life. And then migrated here, it stopped. Okay, and I said I don't miss it, but how come I stopped? Okay, then first time I went home, was 2016. From 2004, I went home 2022 actually. No, 2015. 2015, I went home. Or was it 2014? Anyway, so when I went home, I started having diarrhea again. Right? So I didn't figure it out. I had diarrhea and then came back here. No more. Oh, what happened? So 2022, I figured it out. So it's the water. Because I started drinking just bottled water and I was fine. So I kept doing that. So every year I've been coming home. You grow older, you go home more frequent. Um, so and then last year, no, this year. Remember I was gone for a week? Yeah. So in July, when I had diarrhea again, said, "What's going on?" I was drinking bottled water. I was given ice from the drinks. So I was always, at the hotel and they serve the drinks with ice. And they go, "Oh, it was the ice." Okay. It was still from tap water. Well, they didn't know about my bowel problem. Okay, so you know this, D. Okay. This is not part of the exam, so we'll stop there. Okay, so here's cirrhosis. Okay, we talked about this the whole time. And same. Okay, so I mentioned skincare, correct?
Yes.
Okay. When we say injury, we're really referring to bleeding. Okay.
Proliferators.
No, bleeding from, because they have increased bleeding time,
Okay.
low
I see.
clotting factors. I already mentioned rest, right?
Yes.
Okay, so make sure they're on bed rest. With nutrition, make sure you research your protein before you do any teaching. Right? Because when I was a student, I was hyper vigilant. Educated my first cirrhosis patient. Encourage protein intake, right? And then next thing I knew, my instructor called me, "Hey, Mr. Escardo, come here. What did you teach your patient?" I said, "Oh, I educated them about protein, increase protein, and according to their, budget. I gave them choices. Okay, so eggs, come here." And then she showed me in the patient's room, family member gave them a whole big, like a salad bowl of hard boiled eggs. And the patient was chowing this down like that. What?
So much egg, too much fruit. Damn it. Hard product. What is it?
Can't even break it.
Because there's consequences. Okay, so you have to be specific. Okay, so yeah, go down to your patient's literacy level. Okay. Yeah, I didn't expect them to, to do that. Plus, there's cholesterol there. Okay, so here's the skincare. Right. Liver transplantation. I mean, we did this part of organ rejection. Okay. That's it.